And we are live. Hello, everyone. Thanks for joining us for another Sagely Health webinar. I am here today, as always, with Dr. Jason Sager. Jason, how are you?
Hello. Hi, Jeremy. How are you?
I'm good. I'm good. So, to introduce today's topic, January is Cervical Cancer Awareness Month. And so we want to take that opportunity to talk about cervical cancer, which is a very unique type of cancer. And there's a lot of different aspects of it, and there's a lot of talk on prevention and treatment, and we wanted to look at what are the advances and what are the innovations happening in cervical cancer. So let's jump right in. Jason, could you just give an overview of cervical cancer, kind of how it appears and kind of how it presents to people?
Yeah, absolutely. And cervical cancer is one of the original sort of cancer types that have been studied extensively. Um, Henrietta Lacks was in Baltimore, where I went to at Hopkins, and she was one of the patients who became the first, basically, cell line from which all cancers have been studied. And so, cervical cancer has a lot of history to it, and at the same time, there's a lot of excitement as well because it is one of the cancers and one of the only cancers. There's a handful, but it's one of the cancers that's actually caused to the high extent by a virus, and that virus is called human papilloma virus, or HPV, and many people in the world have it. Something like, I think, from 60 to 80%, depending upon where you live. So most people have HPV. HPV is actually a family of viruses, and there are numbers attached to them called serotypes, but they're numbers. And there are two in particular, HPV 16 and 18, that are known to give rise to cervical cancer or have more of a chance. And so when you look at the percentage of patients who have cervical cancer and are HPV positive, it is 90%, and that's been recorded in the CDC. If you look at the other way, if you do have an infection of HPV, and remember that most people in the U.S. today do,
Right.
the chances of getting cervical cancer is still only 10%. And it's only with those that have the HPV 16 or 18. There's, again, at least 18 other numbers. And the fact is that those are low risk for cancer. So not all HPV causes cervical cancer. And even if you have one of these high risk virus serotypes of HPV, types of HPV, the chance is only 10%. And that's why screening and the pap smear, named for Dr. Papanicolaou from my alma mater at Cornell, that was one of the quintessential screening tests that was introduced early on and has really been quite helpful for early detection and thus an elimination of the sort of pre-cancerous lesions that can come. And just like colon cancer and others, it doesn't go from zero to fulminant cancer in one step. It actually takes several years to get there. And you can see that transformation in the cells in the cervix. And so that's why the pap smear still continues to be very important. But then the other advent that's happened just a number of years ago now, but fairly recently, is of HPV vaccine. And the HPV vaccine is extraordinarily exciting to doctors like me because the hope is that with active prevention of HPV infections, we can actually eliminate cervical cancer. And the data is already in. There's a study that I pulled out from a few years ago where 100% of cervical cancer is prevented and preventable by the HPV vaccine. There are 3 types. Some of them have 1 shot. Some of them have more shots. Doesn't really matter which one you get. They're all very active in prevention. So one says, well, this is great. It's just a matter of time. And that's true, but for 2 things. One is that we know that vaccines take time for people to kind of, take them and accept taking them, figure out that they're safe. And these vaccines are safe, so we do recommend it. And they are given right now to teenagers before they become at the age, because HPV is a sexually transmitted virus, and therefore it's important to establish the immunity beforehand.
Okay.
That today stands at about half of children getting that. And so we stand to do a lot better with cervical cancer in that particular, aspect. And then we'll follow on from there, but let me pause and give a chance for more questions.
I
And
just want to make sure I'm understanding this correctly. So, given on where we're talking about, some percentage of the population is currently walking around infected with HPV. There are many different types of HPV. So, if you went to your primary care doctor, they would probably at some point test you for this. And when that report comes back, they're going to look at that and they say, "Oh, you're HPV 4," and that's not really too much of a
right,
worry.
right.
Or you're HPV 16. Okay, that's something. So, is there elevated screening because of the presence of the particular HPV?
There is elevated screening. And then if they start to see those signs of invasive cancer, transformation of those cells
Right.
towards cancer, they'll actually do some, fairly limited, but, it can be extensive when needed, removal of that area of the cervix. It heals. And so, but they do that removal to try to prevent those cells from basically transforming fully into cancer. And those are all the reasons that pap smears are incredibly important.
Yeah, not all cancers have these type of screenings or options, and so it's really important to kind of know this. So with it's amazing, the hope that the vaccine would then eradicate cervical cancer, but it hasn't been eradicated yet. So and we got some questions related to that, and it's
Yeah.
a great way to enter into it. So if someone it isn't caught early or and so they aren't able to kind of like remove some precancerous cells, so they've gotten cancer, cervical cancer kind of full blown, what are the standard treatments for cervical cancer?
Yeah, absolutely. And yeah, and I think the person that asked the question is very much in alignment with my own thoughts, which is that just because there is an HPV vaccine out there, you know, first of all, does it work to eradicate cancer once it's already formed? And the answer there is no. I actually researched it, and it's logical to think that, well, if it can prevent it, well, then it may be able to eradicate it, even if it does come. But the fact is that the vaccines, and this was really well explained in an article that I reviewed for today, the vaccines create an antibody, like most vaccines, and they attack the virus right when it gets into the bloodstream or right when it gets into the cervix. And so, really, it's blocking the virus from basically setting up camp, from infecting those cells to begin with. Once cells have gone and gotten infected and have transformed into cancer, the virus itself no longer becomes important. And so, even though it was important to set things up, now the cancer is basically going off on its own. And so the vaccines are not particularly helpful because they just absorb the virus. Instead, and this is where we get to what's going on in today's innovative therapies for cervical cancer, many scientists are looking at, again, much like other cancers, trying to excite or otherwise amplify the immune system, find the cancer that has been transformed, the cervical cancer, and cause the immune system to attack it. And there is some beginning promise there, but we still have a long ways to go when it comes to cervical cancer. And that's where a lot of the scientists and physicians are working today. And I'll show you some examples of that in a little bit.
Let me just so you directly answered some of the question that we got, and I want to bring it up. So someone wrote to us and said, "Does the HPV vaccine reduce the risk of recurrence even though someone directly already contracted HPV?" And I'm assuming that they're talking about recurrence of cancer, but I mean they may have been talking about HPV itself, and so. But on the question of cancer, Jason, just you just explained why it's not going to help after you've actually been diagnosed
Right.
or even or facing a recurrence. Um, yeah, so I just want to make
The,
that
yeah,
clear.
I'll add one caveat, which is that remember that cervical cancer doesn't go from zero to full cancer in one step. There is the question if your pap smear should be positive with some of those precancerous or semi-cancerous lesions, the earliest sort of stages of transformation, the actual recommendation from the NIH and the CDC, if you're not vaccinated, is to go ahead and get vaccinated at that point.
Okay.
So again, the thought is that we don't know at what point it becomes limited to interrupt the process. And so it's a safe vaccine, error on the side of getting it whenever it is offered. But once the full-blown cancer is there, and especially if it's spread, distantly, stage 4 metastatic, those are aspects where the prevention vaccine is no longer going to be applicable, but the therapeutic vaccines that excite the immune system are the place that I think is worth a lot of attention.
Yeah, it can be very confusing. I mean, we're talking about an HPV vaccine that, you hopefully will help you not get HPV, which is a precursor of getting cancer. When we talk about a cancer vaccine, we're really talking about trying to create an immune response in the person's body after they have cancer. And
That's
it's
right.
called a cancer vaccine, which people think, oh, that would help me not get cancer, but really it is a treatment post
Right.
diagnosis, right?
Right.
Okay. So then, yeah, let's talk a little bit about if someone is diagnosed with cervical cancer, what are
Yeah,
their treatment options?
absolutely. And again, I will there we go. I will link back to this, and I'm going to share my screen for a moment here. Yeah. So so this is a screenshot of the NCCN, which again is the organization, the National Comprehensive Cancer Network, that goes through and really catalogs the standard of care for all cancer types, sort of one at a time. And they have one specifically for cervical cancer. There's several varieties of cervical cancer, depends upon what cell it came from in the cervix, and there are several types of cells there. So the two being, the major ones being a squamous cell carcinoma versus an adenocarcinoma, and this one's a mixture of the two. There's another version called small cell, which is rarer, and we won't cover that today, but there's also standard of care for that as well. So for the lion's share of cervical cancer, there are standard treatments and they are somewhat effective. The platinums, in terms of chemotherapy, are certainly standard, and radiation is also very helpful in cervical cancer. So oftentimes, physicians and patients will receive a combination of chemoradiation, the chemotherapy with one of these platinum agents, and then the radiation as well. Now, if the patient is already sort of advanced, and this is for, I should mention, for cervical cancer, chemoradiation for cervical cancer that is not it is not really so easy to solve as just to remove it by simple surgical technique. So what I would call is beyond stage 1, or 1A, as they refer to it here. So then the question is, well, if you have a more advanced or metastatic situation, then there will be a first-line regimen that involves immunotherapy. And pembrolizumab today is part of the standard preferred regimen for first-line chemotherapy regimen. And there are other possibilities. So again, the doctor will evaluate which one of these could be best. But really, after the first line, if it does come back either locally recurrent or metastatic, there's a number of different options, but you can sort of see that they start to repeat themselves. And at that point, I would seriously consider getting onto a clinical trial, if not even before or as maintenance after getting that first line chemotherapy, because again, that's where some of these cancer vaccines are being offered.
So I just want to point out with the preferred regimen there, the pembrolizumab, they're saying for PDL1 positive or MSI high. And for anyone who doesn't know, which I didn't until I learned about it, was these are tests that you would have done, but you may need to request. They will definitely be done as part of a tumor sequencing and next gen tumor sequencing, which is kind of the most robust. And so once these tests are done and you are found to be MSI high, meaning that you have a certain type of how the mutations are happening in your tumor, or your tumor is expressing this PD-L1 protein, that means that that's targetable, and that kind of means that your immune system can be activated. So there are tests that can be done. So if you haven't heard any of those terms from your oncologist and you're facing something that cannot be handled from surgery alone, then make sure you're asking about those things and pembrolizumab. Why are you not being offered that if
Yep. Yep. And I agree. We recommend next gen sequencing complete with the MSI high evaluation as well as the PDL1 evaluation, which does come standard at this point as a package with any of these next gen sequencing tests. We recommend that for all patients who are at high risk. And that includes, as you've mentioned, patients who are not eligible for surgery alone, or if they even are eligible for surgery, but the risk is greater than 20% of it coming back afterwards. We would set yourself up, because it takes a few weeks to run these tests, set yourself up with an insurance policy, get the test done so that you know in hand how well, what to use next should it recur.
great.
And so when I looked at, and let me stop this and share a different window here. When I looked at how well the pembrolizumab does, because we know that in PDL1 and in PDL1 positive patients in which these checkpoint inhibitors, for which pembrolizumab is an example of, it's one of the first. We know that in melanoma, for example, it goes from, you could have metastatic disease and you'll have a 50% cure. As I mentioned initially, in cervical cancer, unfortunately, it's not as good. So it does add here and this is in sort of widely metastatic patients. It did add significantly to the number of months during which the cancer was controlled. This being 10 months compared to 8 months in the group that just got chemotherapy. And this was a chemotherapy pembrolizumab combination. It also added to their survival. That being said, 10 months versus 8 months is not particularly exciting compared to 50% cures compared to 0% cures in melanoma. And that's where we come away with saying, gosh, looking at clinical trials, it's really important to do better and in innovative therapy. And so that's where a lot of the emphasis is today. And I can show that to you. And so, this is a search that I did for just what ideas are going on in newly diagnosed but advanced or metastatic cervical cancer, right? And you can see that there are all sorts of things. As an example, here's one of those vaccines. And again, this is a cancer vaccine, not the preventative kind, but the therapeutic kind, the kind that we think could get rid of cancer. And it's being combined with chemotherapy and a few other things, as well as pembrolizumab, that PD-1 inhibitor for the immunotherapy. And so, I like this a lot because you've got the potential here of trying to excite the immune system, but then add in the vaccine so that it's done so in a specific direction that could get rid of the tumor. And so that's one example. There are, we mentioned chemoradiation is a standard, and there are folks trying to add on to that chemoradiation with another. This is a small molecule for glutaminase that they think could be effective. There are other things where, again, some of those rare cancer types like cervical cancer or even that small cell cancer is getting a combination of immunotherapies. And, CTLA-4 and PD-1 is sort of been known to be the classic combination there. It's got some toxicities, so something to discuss with the doctor. But again, it's a way of trying to do better than just the PD-1 alone, the pembrolizumab alone. And then finally, I pulled one out that goes into some of these antibody drug conjugates. That's another class of therapies that are coming down the pike. There's a number of them approved already, about 7 or 8 of them. now, and they seem like they're getting approved fairly quickly nowadays. And so again, it has come to cervical cancer as well. And here's a trial that is studying carboplatin, which we mentioned, with the pembrolizumab that we mentioned, plus bevacizumab, which is an anti-vessel and tumor vasculature agent, and then the antibody drug conjugate. And again, they're really trying hard to help patients who have more advanced cervical cancer right from the beginning. And so these are sort of just some of the innovations that I think are quite exciting. And if I show the map for these sorts of things, you can see that they are they are spread out fairly well across the entire United States. And so really, no matter where you live, it's worth taking a look to see where these trials might exist and if one of them that is appropriate for you.
Yeah, so I touched on it before, but I'd love to hear you talk about it. When should someone hear that bell ring, in the sense that they're going to get offered a standard therapy when they go to their oncologist, and there are also clinical trials? And so when should someone kind of consider clinical trials and the more innovative approaches?
Yeah, uh, you know, we've been doing this for quite some time, about 9 years or so, and I've been working in cancer for more than 20 years. Having seen a lot, I know that the system, that cancer doctors, oncologists often don't have clinical trials in their own hand or don't have the right clinical trial, and they're really thinking about it later. And that's the way oncologists today are trained. Um, think about it when really nothing else is possible. So recall that list of all of those single agent medicines. There was about 20 of them. Well, the oncologist could run down each one of those. The fact is that none of them are going to really create a huge difference at that point, and it would be better to get onto a clinical trial. Fast forward until present, really what we do now is to advise every patient who has cancer to look into clinical trials right from day one, and every time a new therapy has to be looked at. We think that clinical trials hold an amazing potential to do much better than just a standard. Because of the ethics involved with cancer trials, they are very much based on the standard. So again, I showed you an example. You don't have to, it's not this experimental thing or the standard. No, no, no. It's the standard plus the experimental thing compared to the standard. And at the worst, even if it's randomized, you're going to get the standard, but you have a potential of getting something better. And so from my perspective, I advise that every cancer patient evaluate the clinical trials for them that are appropriate and have a discussion with their doctor every step of the way, right from the initial diagnosis. And this really pertains to all patients who are at high risk, who simple surgery is not just going to be curative.
Yeah, I'd add to that. I mean, you're showing the map still here, and so wherever you end up, there are kind of NCI accredited cancer centers across the United States, and these are kind of the best and doing the most research and kind of do the most surgeries. And kind of, if you can get to one of those, and you can Google that term NCI accredited cancer center and see which one's closest to you. If you end up there, you might be more likely to be offered a clinical trial, but not necessarily, because as you can see from this map, they're spread out all over the place. So the one that might be a best match for you might not be at the cancer center you're at. So that's kind of where Sageway Health kind of needs to exist, where we're kind of above it all and saying, like, look, we're monitoring what's going on. We don't have a horse in this race. We're unbiased. We think this is the best place for you because of the research that they are running there, or the research they have run and the knowledge and expertise that they have accumulated, and or
Yeah.
maybe the number of surgeries they do.
Yeah.
Yeah.
And I really wish that the system one day will do this, that, oncologists will have a tool. They don't today have the time. They don't today to really investigate this and evaluate this the way that we do for patients. But the fact is that there's so many motivations that are cross purpose to that. We know that it's important for patients to equip themselves with this information. And unfortunately, no, there is not a single patient, regardless of, their social status or anything else, where they live, that is going to be guaranteed this. The folks that make it onto clinical trials, it's largely by serendipity today. That's 3% of cancer patients. We think it should be much higher. And again, not for benefiting the drug companies, but actually benefiting the cancer patients. That's our primary interest.
Yeah, so we've covered most of the questions that came in, but I want to kind of address two of them really quickly to see if we want to have anything we want to add. So someone had asked about what innovations exist as far as the diagnostics. Are there any kind of upcoming new methods? And you've talked about the Pap smear, which is not a new thing, but it's been around for a long time. But kind of this newer kind of your ability to kind of catch things as the cells are evolving. So anything else you'd add to that to answer that question?
Yeah, absolutely. There are a number of diagnostics that are available today and advanced diagnostics coming down, both in terms of early detection. And we've reviewed, I think, separately some of the blood tests now, whether it's circulating tumor DNA or some of the blood tests that are even getting more advanced, where Grail or Exact Science has detection tests for cancer as a whole that will detect things like cervical cancer. Again, the pap smear is probably better for cervical cancer, but as you mentioned early on, not all cancers have advanced diagnostics, and so that's a place. But the ctDNA can actually be, the circulating tumor DNA can be quite helpful to take a look at not only whether or not patients have it, but to monitor things. And for a patient who's in remission, but is really living in fear of it coming back, having a ctDNA test, which is a simple blood test to take a look at things, can be quite reassuring, especially if it's negative. And so, from my perspective, there are advanced diagnostics, and there's ones that are specific being offered on clinical trials today for cervical cancer. They involve both imaging studies, and so again, PET scans and specialized PET scans to detect that. One of the trials that I reviewed for today is looking at using MRI as a way of providing more precisely guided radiation therapy. So some of these combined modalities. And then there's some other new diagnostic tests, sort of very similar to some of the breast cancer oncotype tests, where they're looking at, it's called Determine RX, where they're looking at trying to figure out what the risk factors are for patients with, let's say, early stage or middle stage cervical cancer, and what the chances that they're going to progress, maybe get some more therapy, chemotherapy up front to try to prevent that from happening. And so, there are a number of different tests. And again, we are positioned to recommend both therapeutic trials as well as diagnostic tests to patients when they come to us.
Yeah, and this might be a good chance to kind of say, like, we've talked about a lot of stuff today and a lot of terminology. And so if anyone has specific questions to kind of like trying to figure out how this applies to you, on the sagelyhealth.com website, there is an option to ask a question, and we will review your question and get you a response that is applicable to the details you provided. So, all these questions have been asked because I wasn't sure if they were talking about diagnostics kind of as a screening, or diagnostics, for recurrence, or diagnostics for like next gen sequencing could fall into that as well. Kind of being like, I want to know about more about your tumor. That's a diagnostic as well.
Yeah.
So I just want to kind of say that the website's there. Anyone has questions on cervical cancer, any other type of cancer, or anything kind of peripherally related, we'll do our best to answer. And so related to that, peripherally in like related, we got a great question. I just want to read it because just the way they put it was great. So someone wrote, I would like to ask about treatments for cervical cancer. It seems so many cervical cancer charities are consumed by eradicating cervical cancer and ways to avoid it, and I'm concerned that those of us who have had it also need research into treatments. We need more successful treatments and cures. There are still huge populations that were not lucky enough to get the vaccine. And amen. And that's what we're here for. So is there anything you would talk about, like how funding works, like the difference between like how advanced treatments happen versus what advocacy groups and charities might be more involved in?
Yeah, absolutely. And I, that is, it's a, the question, the person who posted the question really asked a great question. And it's something that even, today we spent a good amount of time talking about how important it is to get the prevention. And that does take away somewhat from the focus on the therapy side. And it is important for oncologists and drug discoverers, remember that, and remember that there's still a lot of patients with a high unmet medical need with cervical cancer. And so, in terms of the funding of that, I think that the advocacy groups can do better. I do think that the patients themselves, when they can express their voice, and say, "Hey, here we are," and then continuing to sort of message this across the board is the way of raising awareness, especially for drug companies that are, again, looking for, they don't want to make a drug where there's not going to be cancer in a few years. So they're like, oh, well, we'll avoid cervical cancer. But the fact is, I don't see it ending anytime soon. And there are so many patients out there who need our help. And just to counter that, though, I did do some research in that sense. And so let me again share my screen. And what's coming up here is a search for what I would call second line and beyond. So patients who have gotten the standard, tumor has come back or progressed, and now are looking for something else. And again, I think before they were looking at about 21 therapies. Here's 81. Now, in honor of the patient who asked, right? If we looked at breast cancer, colon cancer, any of the big cancer types, it's going to be hundreds of clinical trials available. Here, there's 81. So could we be doing better? Yes. That being said, a lot of the trials that are represented in terms of the innovations are also coming down the pike for cervical cancer. And I pulled out just a handful here, but here you see one, which is, again, another novel combination of immunotherapies to try to do better than just the PD-1 alone. Here you see, we did that one already. Here you see one of those vaccines, the cancer vaccines, with that, where we could potentially be eradicating in a therapeutic way cancer, even when it's at the stage of cervical dysplasia, which is one of those intermediate cancer steps. This one's pretty exciting. There's a whole new group of immunotherapies called CAR-T, and as well as TCR, T-cell receptor therapies. And we've reviewed those as a classification elsewhere. But what I mentioned is that they're coming for cervical cancer as well. And, from my perspective, even though as a class, they haven't really been, amazingly positive yet in solid tumors as opposed to liquid tumors where they've been doing really well, I am hopeful about these. And I do think that they're worth taking a look at. There's a handful, there's multiple others. The antibody drug conjugates we mentioned earlier, and then the importance of getting tumor sequencing, because here's one that requires this DDR2 gene. And if you have it, they think that you'll be responsive to an ATR inhibitor. These are targeted approaches that are looking specifically for issues in the tumor that doesn't exist in the body that we can target. And again, that varies from patient to patient. So you need that tumor sequencing in order to have that. And just wanted to, and here's one of those advanced diagnostics to predict which immunotherapies are going to work best with this OncoPrism assay. Those are all very good. One of the points I missed before that I had, but I may have missed it, was just fertility sparing, that there are trials looking at preserving fertility for patients whom that is of interest. Cervical cancer, as well as other cancers, can happen to very young people. And it's important that if you are interested in fertility later in life, that you talk to your doctor early about that. And so, I just wanted to kind of say, even with 81, if we look at the map, again, it's going to, it's spread out quite thoroughly across the entire U.S. And, as we dive into this, it really doesn't, matter where you live. There's something that is likely to be available, for you to take a look at. And so from my perspective, worth checking that out. We will be producing videos and hopefully courses that will help patients to understand how they can check out clinical trials. But until that happens, we are here on a daily basis to provide patients step-by-step guidance that will help them to achieve their maximum success with cancer.
Absolutely. I mean, I would say that, there are over 140 different types of cancer. Only a handful of them are known to be caused by a virus. And because this one is caused by a virus, a vaccine actually does open this window of hope of eradicating it through the vaccine, through prevention. So I think there is an excitement around that in cervical cancer, but that can definitely kind of gloss over the treatment options. But as I say, as you're addressing the treatment, you're looking at that and saying, like, well, a lot of those were for solid tumors overall. So a lot of the advancements in other types of tumors, other types of cancer, like lung cancer, I saw the ovarian cancer. These are things that will contribute to the success of cervical cancer treatment. So that's what gets so confusing when people go to clinicaltrials.gov, which, if you don't know, is the government website, because you're looking for your cancer, but it may not jump out at you because you just might be one of the buckets that they're looking for in that trial. So I can't stress enough that we can help you with this. Like, we're available to help you with this, to kind of isolate the ones that are the right for you, and at least get you in front of the people who are running them, so that you can ask those questions and you can be evaluated. Because if your doctor isn't suggesting it, that doesn't mean it can't be suggested. And that's the gap we're really filling here.
Yep, absolutely.
All right. Well, I think we can wrap it up there. This has been great. We didn't stay under a half hour as we tried, but we're under 40. So, um, like I said, I will be posting this video, and we are available for questions. It's sagelyhealth.com. And yeah, we'll be back soon with our next webinar.
Yep. Thanks so much, Jeremy.
All
Thanks so
right.
much,
Thank you.
everyone. Look forward to speaking to you soon.